inviting and having me here. And I'm going to talk a little bit more about the toric trifocal model. So I think our main aim is to get close to target and to get a good predictability of our outcomes. And we all try to stay in between plus minus 0.5 diopters. But actually, that is not that simple. And if you look at previous studies, like from Warren Hill, for example, you can see that there's a prevalence of corneal astigmatism of already 18%, and that is just for the plus 1.5 diopters and more. But also what we don't really like talking about is that if we perform a standard cataract surgery, in many cases the astigmatism can actually increase due to our incisions. And most surgeons still don't look that much at their surgical induced astigmatism. So if we just look what we can correct, we would have 40% of patients with an astigmatism greater 0.75 diopters that would already benefit. And if you saw the slides before, there were, I think in the first or second presentation, a patient with 0.75 diopters astigmatism who had a little bit less uncorrected visual acuity. And if you just go a bit higher on 1 diopter, it's already 30% that can still or already use a toric correction. The other thing is, if you correct this astigmatism, a lens needs to sit stable, because even a little bit of misalignment, like 3 degrees, reduces efficiency by 10%. And if you look at the manual calipers, for example, the degrees are marked in 5-degree steps. So that's another thing. If you correct it, you need to correct it very precisely. And here the very important part is you need to have a good IOL calculation, you need to take the anterior and posterior cornea into account, and you need to have good markings, a digital system, or you need to be experienced with marking the cornea manually, or even with the laser having the markings on the capsule, like with the Lenser or other systems in the cornea. So you did all your homework, you have all that stuff prepared, and I'm going to show you some of our data that we evaluated in those patients. It's not that many yet, but you will see later. I think most of you already saw the Acriva Trinova, and what is also very special about the lens is the wide diopter range from 0 to 32 diopters and cylindrical from 1 diopter up to 10 diopters to create to compensate higher astigmatism. I think that slide most of you have seen already, incision size around 1.8 millimeters, blue light filter, and the sinusoidal profile. Also, there's a very good calculator available that you can use for calculating the right IOL power for implantation, which is still worked on, and they're going to start implementing the posterior cornea. But if you look a little bit more into this sinusoidal profile, you can see that you have less loss of light, wider depth of focus, a good MTF in all distances, and outstanding visual performances, but that you saw already in the presentations before. But if you compare that to other technologies and look at the profile, think about aerodynamics for cars, how smooth the wind glides over the car. That smoothness is the same smoothness you use to divide the light on different focal points. And that's why you have less stray light, and that's why the vision is becoming more smoother with an IOL profile like that. So you can see here one of my implantation videos. I always implant the lens through a 2.2 millimeter incision. And I'm a bit lazy, that's why I don't put viscoelastic in the anterior chamber. I just use an irrigation port, because then basically I'm done. And when I rotate the lens under the irrigation, it sits in place, very handy and very easy. So it saves you like 10-15% of your time during the surgery. And it works very well because the lens is flexible, easy to rotate, but it sits very stable, even it feels like it is a very soft material. So those is our preoperative data of our patients. We have 4 binocular patients evaluated after 3 months and implanted around 20 at the moment. And you can see here the visual acuity in several distances, also in 80 centimeters for intermediate and 60 centimeters for intermediate. And you see even in those set distances, you already nearly get a very smooth curve. And that is not a defocus curve at all. If you look at the defocus curve, we get similar results with the toric version compared to the defocus curves you saw before. It's a very smooth kind of EDOF transition from distance over very good intermediate into a really good functional near for those patients. We also did some optical quality measurements with the HD analyzer, and you can see here they all have a predicted outcome of around 20/20 00 logMAR with a very good optical quality and a really reduced amount of stray light in those measurements. So as the symposium mainly is about photopic phenomena, we also evaluated that. At the moment, we mainly did a subjective part where the patient can adjust the halo and glare. For the McAllen questionnaire, our sample size is too low at the moment. So we have two evaluation forms. One is we graded it and categorized it in a non-mild, moderate, and severe form. And then also we calculated the mean and medians of the adjustment of the patients. And you can see here those images are nearly comparable to a monofocal lens. And most patients were in a mild range. If you take a monofocal group of patients and you explain them what halo and glare is and let them adjust it, that's a very similar outcome to the outcome you see here. So in conclusion, there is a new solution for presbyopia correction, a very smooth transition in the intermediate area with functional near. It's a good and easy to use plate haptic design, easy to implant in the eye, easy to rotate, but sitting very stable, and it has a low incidence for this photopsia. So always keep in mind your individual needs of your patient. Where does the patient want to see? How does he want to see? Would he accept this photopsia or wouldn't he? And always think about that astigmatism can really reduce the optical quality of a patient and with that also his lifestyle. So thank you very much for your kind attention.